Hi everyone, I'm Kelly Phillips. I'm the Skin Integrity Nurse Consultant for Doncaster and Bassetlaw Teaching Hospitals. I'm here today to talk to you around how we can rethink MASD management for neonates. Within this session, we're going to be looking at how managing neonatal MASD differs from managing adults and how and when it presents. And through that, we'll look at prevention and management approaches and how we can translate that into practice using pathways and evidence-based approaches, whilst making sure that we're looking at protecting as well as treating. So to give a bit of background around the skin, so the skin is a complex and dynamic organ that performs several vital functions. It forms that physical barrier between the organisms and the environment. So it provides UV protection, it also prevents invasions from those pathogens, and it regulates our body temperature and sensory perception as well. The maturation process of the skin starts at birth when the adaptation of the skin comes into contact with that dry environment. Moisture of the skin increases that friction forces on, softens the skin, which in turn weakens the outer layer. And that's where we need to be putting preventative plans in place to try and reduce our friction forces and obviously weakening the epidermal layer. So when looking at the skin structure, it consists of several different layers. So we've got our epidermis, our dermis, subcutaneous fat, adipose tissue with supporting structures. When we're looking at the epidermis, that's our most outer layer and it's there for protection of our underlying structures, with 90% of it being containing the keratins, which produce and toughen fibrous proteins that protect our skin from damage. So it's a bit of it like a shield to our body. The remaining 10% there are cells that provide our colour, absorb our UV light, and also protect our body from bacteria. Below the epidermis, we've got our dermal layer, and this is our inner layer that's much thicker than our epidermis. It's situated between the epidermis and our subcutaneous layer, and its primary role is there to sustain and support the epidermis to give us that structure of our skin, but also to cushion the deeper structures from mechanical injury or force. So to protecting our subcutaneous fat and supporting structures. It also provides nourishment to our epidermis and plays a very important role in wound healing when the epidermis layer has been broken. We then do have our subcutaneous tissue, and it's not actually part of the skin, however, it lies between the dermis and attaches the skin to our underlying structures such as fascia, muscle, tendon, ligament, and bone. When we're looking at neonatal skin, though, for our full-term neonates, during their skin barrier development is very much impaired, so their skin function will result in being very vulnerable, particularly to any chemical or pH changes, such as urine or feces. What that also does, because we're in a vulnerable state as a neonate, we're then at an increased risk of having microbial infections invading our skin, and which then can possibly compromise the general health of the infant. When we look at premature babies, so our preterm neonates, they're at an even higher risk because it's not until around gestational age of week 34 that we start that completion of our epidermal maturation. So during their first weeks of their life, if they are premature, they have an even less developed skin barrier. So it's extremely important that we're evaluating the risk of their skin breakdown by those external forces. When we're comparing neonates to adults, there's even further differences that we need to take into consideration for our neonatal babies. The number of differences consist of looking at how they've got a reduced ability to thermoregulate, how they've got an increased body surface to weight ratio. They've got an increased transdermal epidermal water loss as well, so it's how we can make sure that we're keeping that moisture level balanced within the skin. They've also got tendencies towards epidermal stripping. So anything that we're putting on their skin that could be adhesive, we're also at an increased risk of losing that epidermal layer. They've also got an immature immune renal system, so that increases their risk of infection. So again, it's vital that we're protecting their epidermis as much as we possibly can. They've got a limited mobility. They've got that inability to verbally communicate with you, particularly if they're in pain, and they've got many different ways of expressing their in pain as well. So there's lots of additional elements that we've got to take into consideration compared to adults when we are caring for our neonatal caseload. MASD is an umbrella term, and within it we've got 4 different categories. So it covers incontinence-associated dermatitis, known as IAD. We also have peristomal complications. We also have intratago, and we also have peri-wound moisture-associated dermatitis. But when we talk about MASD and neonates, it mainly presents in the form of IAD, and it's often related and referred to as nappy rash. That's because the incontinence-associated dermatitis, which is the exposure to urine and feces, is changing that pH level on that very underdeveloped skin. The skin in the perineum, nasal cleft, buttocks, and genital areas may start to present as either pink, redness, can start to become very irregular in shape in terms of that colouring, but sometimes it can be quite linear as well, with diffusing edges depending on that locality of that skin damage or skin irritation. The skin often looks inflamed, excoriated, and that can be both intact and broken skin. So as you can see from the image on this screen, we've got that red excoriation around the edges. We've then got that broken skin showing that granulation, and it's got diffused edges, but it very much looks like a butterfly in terms of how it's very symmetrical on both sides, and that's from where the feces has been in contact with the skin and sitting on the skin, changing that pH level and acting and reacting similar to how a burn would do, and it's breaking down that skin barrier. This was a neonate that we cared for where they was going through withdrawal symptoms following their mum's having substance misuse while she was pregnant. And unfortunately, in the early weeks and days of this baby's life, they was going through withdrawal, which increased the amount of feces that they were having, and it was in a very loose format as well, which increases that risk of that pH chemical changing on that skin. It's really important that we do identify that cause of what's causing that MASD, and particularly IAD in the neonates. For the baby that we've just explained, that was the feces that was coming into contact. And by enabling us to identify what the cause was, we can start to try and address that as much as we possibly can, so that we can start to keep that skin clean, dry, and also maintain the hydration. Barrier preparations are used to prevent feces coming into contact with the skin, so we can put a layer of that barrier onto the skin. So if there is feces or urine coming into contact, it's sitting on the barrier rather than the skin. And what that also does, it reduces humidity and the risk of maceration, as well as minimising that transepidermal water loss. So when we're looking at a prevention and management approach, it's really important that we're looking at several different factors to ensure that we're protecting and restoring that skin. The first one that we really need to consider is cleanse. And this is where the skin should be cleansed with a pH balanced cleanser. And one particularly containing surfactant is even better, because what that enables that product to do is break down the debris, including feces, so that it reduces the risk of rubbing or additional contact to the skin. That surfactant will break that down gently. Also, a cleanser that's non-rinse as well, which will prevent, again, that extra friction and causing in that cleansing process. We've also, though, got to consider controlling that moisture. We've got to get that right balance. So using an absorbent dressing or product that's enabled to take away that excess moisture to balance the hydration with a barrier protectant will be effective. We've also got to think around treatment, and that treatment consists of a fungal anti-topical treatments, but also some adjuncts, and that could be antimicrobial cleansers for local breakdown, or enzyme angiogels where infection and inflammation coexist. So it's looking at what products we can have in place that is able to treat our fungal, but also protect from our bacteria as well. And then looking at that protecting that skin barrier. So considering a formula that can absorb excess moisture, helping to maintain the correct balance and moisture needed for healing, but also then using a product that forms that protective barrier that is gentle on the skin and can be used for long term as well. So it's not something that we could only use for a few days, example like a steroid treatment where we'd only recommend it for a certain time frame. We're wanting something that we can use long term to help with that prevention of further damage once the area is healed. And also then that management. So we're looking at managing those associated symptoms. So looking at how we can have a product that repairs that broken skin and also keep the intact skin nice and supple and moisturised. And considering a product that helps remove microbes and bacteria like we discussed around that fungal element, but also looking at that bacteria and that biofilm as well and protecting the area from any infections. We're looking at then with those principles, what are we going to implement that to make sure that all of those principles are aligned and done effectively and appropriately. It's vital that we're also looking at those recommendations, and that could be evidence-based practice that's local, national or international. And there are lots of national recommendations out there that we can utilise to help support our care planning. A key factor in implementing evidence-based practice is to reduce that unwarranted variation. And by doing that, what we can do is put together some really focused interventions to help formulate a step-by-step process for people to follow. The best practice statement that was published earlier this year for understanding types of MASD, prevention, identification and management highlights how a structured skincare regime can really assist with that reduction in numbers of instances of MASD. And because of that, the evidence-based practice is crucial for improving those patient outcomes, and it allows that guidance for that clinician to use the most effective, scientifically supported treatments leading to faster healing, also fewer infections and ensuring cost effectiveness. The translation of those recommendations, though, can sometimes be really confusing. So for a clinician that's really busy and working in a department that's really busy with multiple different factors happening, or maybe by themselves out in the community with very limited access to support, what we want to be able to do is translate them recommendations into something that's really manageable for them to follow whilst they're with the baby or with the parents, to make sure that we'll have that seamless transition of care, and it's all based on those recommendations. So to be able to translate those recommendations around the prevention and management of MASD, a clinical pathway can translate those requirements into practice by providing that really streamlined, easy to follow process. And by doing that, we're promoting that safe and logical recommendations are put in place. A clinical pathway can also help facilitate change. So if this is something very new to the practice that you're implementing in your organisation, that pathway can help people understand and do some micro learning in terms of understanding the processes around the definition, the aim and the steps that they need to follow. So it helps standardise that practice and promotes patient safety and improve those patient outcomes. This is an example of the pathway that we have developed across Doncaster, and this is a seamless transition across all services in Doncaster that provide wound care. So it covers acute hospital admissions, it covers primary care, community care and out-of-hours services as well. So no matter where that patient is in that system-wide care provisions, they're going to be receiving the same level of care and standards that are required. And it's really important that we have a pathway that is visual, that we provide definitions and also risk factors, and making sure that we're including images as well as definitions when we're looking at diagnosis. And having that process step by step, particularly looking at product specific definitions and images, will help that easy translation for that healthcare professional to know exactly what they need to do at the right time, at the right place for that patient. And also including prevention and management in one single pathway will also help with that continuation of care, depending where the patient is in their journey. Having that pathway in that format increases that understanding. It also increases the usability. It also increases compliance, awareness and transparency. And they are all things that we've seen since we've implemented this pathway across Doncaster, that the staff members now understand what they need to be doing at the right time for their patients. This is just breaking down that top half of the pathway that I've just shown you, and it just shows a little bit clearer in this image around how we've defined what IAD is and that it's targeted to our neonates. We've also put in there some risk factors as well, particularly explaining how premature babies are at an increased risk of IAD. Then we put some information in there around what we would require from an assessment. So that would be an assessment in terms of the skin, the wounds, and some clinical photography there as well to support that. And then looking at that diagnosis and breaking it down into 4 factors. So what does a healthy skin look like? So again, we've got that definition and that image there. Mild IAD, moderate and severe. So they can see visually what they're seeing right in front of them with a patient, which part of that pathway they need to go on to follow. And then with this second part of the pathway, this is where we're concentrating on that protecting versus treatment. So rather than having 2 separate pathways, one for protecting and one for treatment, we've been able to bring them together. And again, following that 4-step process of what they need to do, following that assessment, we're going to undertake cleansing no matter where they are on that pathway. But when we come to protecting, restoring and treating, we're going to follow the principles of whether it's healthy skin, mild IAD, moderate or severe. And then there's also some then additional information around onward referral. If that patient has got active IAD and they're not seeing any improvements within a set time frame, what they can do to escalate that to one of the specialist teams within the area. When we was looking at what products we wanted to implement and use within our pathways, particularly around that treatment, so when the IAD was getting to that more moderate and severe stage, we wanted to ensure that we were looking at moisture, debridement, comfort, protection, and antimicrobial and antifungal treatments. And that was to make sure that we was following those steps that I identified earlier that are documented and recommended in the best practice statement. We wanted to ensure that the product we were using could meet all of those requirements. So some examples of that was we were looking at products that could absorb excess moisture, helping to maintain that correct balance of moisture in the skin that is needed for healing, but also looking at what could also do that kind of cleansing and debriding element of that wound bed to speed up healing, whilst also protecting the skin by helping prevent further damage from moisture, but also making sure it's very comfortable so it could reduce any pain, particularly around products that was non-sting, making it suitable to be used on that damaged skin as well. And also then that antimicrobial and antifungal element, so we could ensure we were helping to destroy any microbes and reduce that bacteria from biofilms and protecting the area from infection, whilst also treating against broad spectrum of microbes, including Candida. The product that we assigned as being first line was Flamanol. And we went with Flamanol because there was clear evidence that that could be used in that full circle of that we described earlier around cleansing, controlling moisture, treating fungal, protecting skin barrier, and managing those associated symptoms. It can be used across an array of different MASD across all of those 4 categories, but in particular, we found it really useful in terms of the IAD for our neonates because it was that comfort, pain, and non-sting application as well. It promotes healing by creating that moist wound environment and protecting skin for further moisture-related damage, and also containing those antimicrobial enzymes to fight infection and the alginate to absorb excess moisture. And then with its tacky nature and the consistency, it also helps adherence to that already moist skin to provide that barrier to enable the skin below to start to heal. In summary then, when we're looking at rethinking about MASD, particularly in neonates, we need to make sure that we are understanding that their impaired skin function is even more vulnerable than those in adults, and that even in premature babies, theirs is even further vulnerable than the neonates born at full term, particularly around the urine and faeces. And that's why it's important that in terms of those 4 different categories of MASD, a real focus is pulled down on IAD when we're looking at neonates, so we can ensure we're reducing the risk around urine and faeces sitting on the skin and causing any damage. It's important that we do include prevention and management so that we're including all those elements that we've spoken about around cleansing, protecting, restoring and treating the skin. And by implementing pathways and evidence-based practice, what you are able to do is provide that assurance that you're putting principles and processes in place to improve our patient outcomes through that streamlined process to reduce variations. And having that pathway that's able to look at both protecting and treating will ensure that we've got that logical step up and step down approach. So again, reduce that confusion to the clinicians or even the parents of which pathway is it that I need to use. This allows that easy transition up and down that step-by-step process of healthy skin all the way up to severe IAD for them to follow and implement as and when best suited for that patient's skin. Thank you for listening to this presentation on rethinking MASD for neonates. And I'm now going to hand over to Sol for our next presentation. And I look forward to taking any questions following Sol's presentation.
Thank you. And thank you, Kelly. Hello, everyone, and welcome. I'm thrilled you could join us today. Really excited to be with you. My name is Solange Gaspar-Pickering. I'm the tissue viability lead nurse at University Hospitals of Leicester. And I've been working in tissue viability for over 8 years now across 2 different NHS trusts. And during that time, one issue has consistently challenged us, which is moisture-associated skin damage, or MASD, like we will call it going forwards. So today we're going to dive into what MASD really is, why it matters for patient safety and dignity, and most importantly, practical steps you can take to prevent and manage it effectively in adult patients. I would be really interested as we go along this presentation that you could share with us how often you come across in your setting of moisture-associated skin damage being either misdiagnosed or mismanaged. It would be really interesting to hear your experiences. So let's get started and we'll do a brief introduction to what MASD is. So really the image is there to imply that it's it's when the skin gets overwhelmed with moisture exposure. So it refers to moisture-associated skin damage, refers to inflammation and erosion of the skin, which is caused by prolonged exposure to moisture. And that could be from urine, feces, sweat, or wound exudates. And it is a common yet under-recognized condition, and it can significantly impact patients' comfort and increases the risk of pressure ulcers, prolonged hospital stays. So MASD is not a pressure ulcer, but can increase the likelihood of one developing if not managed appropriately. And so this condition affects patient dignity, the quality of life, and its prevention and management are essential components of effective wound care. So this section introduces the concept of MASD and it highlights its clinical significance in adult patient care. And this is all because recognizing and addressing it early is key. So as I previously mentioned, MASD occurs when moisture disrupts the skin natural barrier. So this can lead to maceration, inflammation, and eventual breakdown. And this condition can manifest in several forms, each associated with different sources of moisture. And there are 4 primary types of MASD, and they can include incontinence-associated dermatitis, so your IAD, how it's more commonly known, and it's caused by prolonged exposure to urine or feces. You have another one, which is an intertriginous dermatitis. So it's a bit of a mouthful, but which occurs in skin folds due to friction and trapped moisture. So this is due to the sweat. It could be peri-wound moisture-associated skin damage, which will develop from excessive wound exudate. Or the last one could be peristomal MASD, which will develop around stomacites due to the leakage. And really, none of them should be underestimated as they can be incredibly painful. With this slide, so it's not my expectation that after this webinar, you would have memorized all of these layers and all these complex names. What I would really like you to take away is that although it's complex and with many layers, the epidermis is really thin. But despite this, cells can take between 14 to 28 days to reach from the stratum basal to the stratum corneum. So when you're implementing a care plan, um, we should have in consideration that time frame to allow the regeneration of the skin. So basically, don't feel tempted to abandon a care plan after only a few days, as you might think it's not working. So just try and persevere and always bear in mind that time frame. So Kelly has already gone through the layers of skin and what happens in neonates, but it's important to understand what happens then as we get older. Um, so as you can see here, one of the main things that happens is the epidermis becomes thinner. So this means there's reduced cell turnover. And with age, the epidermis becomes thinner because the keratinocyte production slows down. And this means there's fewer newer cells reaching the surface, reducing the skin's ability to repair itself after injury. And a thinner barrier also offers less protection against friction, moisture, and irritants. There's also a loss of collagen and elastin. So this causes a reduced structural integrity. So what does this mean? So some of you might be aware, collagen provides tensile strength, and the elastin gives flexibility. So aging reduces both of these, making skin less firm and more fragile. And that's why a lot of us will be using moisturizers rich in collagen because we're trying to keep our skin as plump as possible. So all of this increases susceptibility to tears, to shear forces and breakdown under pressure or moisture. There's also a reduced blood supply, and that means there is slower healing. There's a microcirculation decline with age, and there's reducing oxygen and nutrient delivery to the tissues. So this means wounds will heal slowly, and any damage, such as MASD, like we're talking today, will take longer to resolve. Um, and a poor perfusion also means there's less efficient removal of waste products, which can again delay recovery. There's also a decreased sebum production. So that leads to your dry, cracked skin. And this happens because the sebaceous glands become less active, so leading to drier skin. And dryness increases the risk of fissures, of micro tears, which can become entry points for infection. And then when you combine this with moisture exposure, it can create a high risk environment for MASD. And then last, there's a flattened dermal epidermal junction. So it means there's less cushioning. So the junction between the dermis and the epidermis flattens with age, and this reduces the mechanical support. So this makes skin more vulnerable to shear and friction forces, and especially in areas like skin folds or bony prominences. There's also an impaired immune response, which means higher risk of infection, really. So what happens is aging affects the immune surveillance in the skin, reducing the ability to fight pathogens. This means any breakdown, again, such as MASD, has a higher chance of becoming infected, and then healing is delayed. So looking now at clinical differentiation and the prevention, this is, you can see here on my screen that at UHL, we have created this document to support staff in differentiating between MASD and pressure. And it highlights the different characteristics in both types of skin damage. Differentiating moisture from pressure ulcers is essential for the appropriate treatment and documentation. And MASD typically presents as diffused skin damage with irregular edges and a superficial erosion. And it's often in areas that are exposed to moisture. So if anyone ever tells you someone has moisture damage to their heel, always question yourself, where would the moisture be coming from if it's not from a peri wound? And in contrast, pressure ulcers are usually localized injuries over a bony prominence. It can extend into deeper tissue layers. And this is one of the main differences. Um, your MASD will always be superficial. So if you are reviewing your patient and you're visualizing deeper skin being affected, then that means you're not dealing just with MASD, and there's something more likely to be pressure, because what this can lead is into having combined lesions that can start by being moisture and then developing into pressure ulcers. And so really, misclassification can lead to incorrect treatment plans, affect reporting accuracy. And so this document provides guidance on distinguishing between these conditions through clinical assessment and highlighting the key visual and anatomical differences. And accurate identification ensures that patients receive the most effective interventions, and the healthcare providers maintain compliance with the documentation standards. So prevention strategies and your risk assessments. So preventing MASD begins with early identification of at-risk patients and implementing proactive measures. Risk assessment tools such as Purpose 2, which you might be familiar with, can help clinicians evaluate the vulnerability based on moisture exposure, their mobility, and their skin condition. So regular skin assessments, particularly in high moisture areas like the sacrum or the skin folds, are vital. Preventative strategies include maintaining skin hygiene, using moisture wicking materials, and applying barrier products. And so education of staff and consistent protocols are also key to reducing incidents. And this outlines practical steps for integrating prevention into the daily care routines, and emphasizes the importance of vigilance, especially in high-risk patient populations. So in terms of management and clinical practice, effective management of MASD involves selecting the appropriate skincare products and interventions tailored to the patient's condition. So things like barrier creams, gentle skin cleansers, and absorbent products help protect and restore the skin barrier. So dressings should be chosen based on their ability to manage the moisture without causing a further deterioration or a further irritation. And over cleansing and the use of harsh soaps should be avoided to prevent additional skin damage. Um, Really, what's important is that interventions must be individualized. What is fit for one patient might not be for the other. And so I'm considering the type of MASD and the patient's overall health status. So to give you a specific example, if someone has IAD, so urine incontinence associated dermatitis, don't automatically place a pad on them. They might just need support with a better hygiene routine after passing urine or opening their bowels, and that might be enough to support their needs and support their skin not to get damaged. So the following slide provides guidance on the evidence-based product selection and practical tips for implementing skincare regimens in clinical settings. So here you'll be able to see this is another document, another pathway we use at UHL, which guides the staff and supports them in knowing what product to be used. You'll notice that from moderate to severe skin damage, what we request is that a referral to the continence and the tissue viability team is completed for treatment advice. This is where we will then step up on the products. This will suffer changes because what we are finding is that the more we are educating staff, actually, the more confident they are in managing some MASD, and therefore they can implement all of this care plan before we get to the patient. So try not to delay patient care. So really, in all of this, where does Flaminol fit? So in UHL, the tissue viability team recommends using it from moderate to severe skin damage. And we recommend applying it every time the skin damage is addressed. So if it's related to continence, every time the continence is addressed, the patient is cleaned, then to reapply again. And really, what is Flaminol? So it combines alginate, which is a highly absorbent material, with enzymes in a gel matrix, and this unique structure allows it to absorb excess exudates, maintain a moist wound environment, and continuously support autolytic debridement, so helping remove necrotic tissue gently without harming any healthy cells. It has an antimicrobial action without cytotoxicity. So unlike some topical antimicrobials that can damage healthy tissue, Flaminol's antimicrobial effect occurs within the gel matrix and not directly on the wound bed. And this means it kills bacteria without harming viable cells, making it safe for both skin and wound tissue. There is no known resistance, so this is a major advantage in an era of increasing antibiotic resistance, and makes it a reliable option for long-term use in managing moderate to severe MASD as well. Comfort and patient experience. Patients often will report that Flaminol is quite soothing and quite cooling, which can significantly improve their comfort and actually as well their compliance. And its gel consistency also reduces pain during dressing changes compared to dry dressings. And the clinical role in MASD, it's recommended for moderate to severe MASD, especially when there is heavy exudate or a risk of infection. And it should be applied again in line with what UHL also recommends after addressing the source of moisture to ensure there are optimal results. So lessons learned from practice. So what does this mean? So clinical experience has shown that delays in recognizing and treating MASD can lead to significant deterioration, including the development of pressure ulcers. And so it's important that there is a multidisciplinary collaboration, including input from tissue viability teams, for its effective management. Education and awareness amongst healthcare staff is critical to improving outcomes. And this section shares lessons learned from real world practice that can highlight both successful interventions and areas for improvement. Emphasis is placed on the importance of timely assessment, consistent care practices, and ongoing professional development to enhance the quality of care for patients with MASD. Supporting tools, and to conclude, so accurate documentation is a cornerstone of effective MASD management. It ensures continuity of care, it supports the clinical decision making, and facilitates audits and quality improvement initiatives. The digital tools, such as your electronic patient records for the ones that work with one, the assessment frameworks, they all help standardize documentation and streamline workflows. And these tools enable early detection, a prompt escalation, consistent application of care protocols. Um, so this explores how the digital solutions can enhance MASD management, reduce duplication as well, and support more of a data-driven approach to patient care. So in summary, MASD is a prevalent but manageable condition that requires early recognition, appropriate intervention, and coordinated care. The key takeaways really include understanding the different types of MASD, differentiating it from pressure ulcers, implementing prevention strategies, selecting the suitable products, and leveraging the digital tools for documentation. A multidisciplinary collaboration and continuous education are essential to improving patient outcomes and reducing this avoidable harm. This webinar will aim to equip you as healthcare professionals with the knowledge and practical tools needed to manage MASD effectively in adult patients. So please do let me know if you've got any questions or points for discussion. And thank you very much for listening.
Thank you, everybody, on behalf of myself and Sol, for joining us tonight and staying with us for both of our presentations. We really do appreciate your time coming in and listening to our information around MASD. We have got a couple of questions that have come through, so myself and Sol will go through them and answer them if that's okay. Sol, do you want to just start with the first one, or do you want me to?
Yeah, of course. No, I can start. So the first question, what are the main differences between newborn and adult skin? I will let you answer about neonates, but obviously we have gone through it a little bit. The main difference is obviously well on an adult, and especially as we age, is really the difference in the thinner epidermis. It's the instability between layers and less production of all the goodness that we have as adults. And obviously that increases the susceptibility to all sorts of injuries. There's lack of blood supply, which will then reduce oxygenation to the tissues, will delay healing, will delay the ability for someone's skin to bounce back. So basically, it takes away as we age, it takes away the resilience from our skin to respond to any injuries.
Yeah, and I think it's important to understand that within neonates, as Sol's already explained, that thinner layer, particularly with the epidermis, is about 30% thinner than it would be in a child or as progressing into teenagehood and adults. And because it's thinner, it's got less collagen in there and less fibrins, so it weakens that support between the epidermis and the dermis. So it runs a risk of it not only being an increased risk of the skin breaking to begin with, but then that deterioration can happen as well. That's a lot greater in terms of that time frame compared to an adult skin that's a lot more it's stronger and more sustainable to those injuries. So it is really important, obviously from a prevention point of view, that we get in there straight away with any neonates that we know is at risk of that MASD, so we can try and prevent it from even getting to that first stage, let alone obviously deteriorating throughout the different stages within MASD. So the second question was aimed at my presentation. So it says, how important is it to diagnose a stage of MASD in neonates? And I've kind of just answered that really. So it's really important that we diagnose a stage where it's in terms of healthy, mild, severe, moderate or severe. because what we want to do is capture it at the right time so we can make sure we're putting those right cleansing, protection and restoring and treating elements in, depending on where it fits in those 4 stages of diagnosis, to try and prevent it from deteriorating further, with it being obviously more susceptible for that deterioration to happen. So in terms of our pathway, that's why we've built that in as a visual tool in our pathway, so the clinician and or even the parent can see at what stage that MASD is at, so they can clearly see then what products and what procedures they need to follow after that. Sol, do you want to take question 3?
Thank you. Yeah, so question number 3, really aimed at both of us. And it's what cleanser with surfactant would you recommend? Would you advocate for emollient as a soap substitute? So certainly within my trust, we won't advise a specific cleanser with a surfactant because we will often say warm water with your emollient is sufficient to clean your skin to remove the fecal enzymes. And then if you're using the Flaminol, that's got your antimicrobial effect there. So whilst we could use a surfactant as well and really get on top of that bacterial load, actually we find that it's quite effective by using the Flaminol, that it's sufficient to get on top of it. And so obviously also bearing in mind how cost effective your care plan is. So I don't know about you, Kelly,
Yes,
within your little ones.
yeah, so within neonates, we do recommend a cleansing spray, and there are several on the market that you can look at, and they all do the similar kind of same properties that have that surfactant in that'll break down that feces, so you're not having to do as much contact to the skin when you're cleaning. So in our organisation, we do use the Mediderma cleansing spray, but like I said, there are other ones on the market. There are some from other companies, so ProShield, for example. But there are also some wipes as well that are like a 3-in-1 wipe that can provide that same coverage. So we do recommend it for neonates, mainly because again that they're at higher risk. So we can try and get on top of it as quick as we possibly can without causing any additional distress or discomfort for them. And we don't use emollients as soap substitutes, but you can. I know that there are, for example, there's a double base gel that can be used, that's got a surfactant in it. If you just apply water with it in your hands, it acts as that soap substitute. But if you are wanting to go down that route, what I would suggest is you speak to your local pharmacist, and they will be able to look at what there is out there that's suitable for what you're trying to cover. But there are products out there that aren't emollients that can do the same in terms of removing that debris with that surfactant.
Yeah, certainly. And just to add, you know, just nationally, there are so many products available. I think we would be here for another few hours discussing them all. So it's just looking at your care setting and what have you got available, and look at how effective it can be. And like I said previously, cost effective.
The next question again was for myself. So it's, can this neonatal pathway be shared with us to adapt? Absolutely. So if anybody's interested in the pathway, if you want to contact your local Flaminol rep, your Flen Health rep, they will put you in contact with myself. I'm more than happy for my email to be shared with anybody that's attended this evening. And we can send that across just with what we would require as an acknowledgement on your pathway, just to acknowledge where it's come from. But definitely, let's not reinvent the wheel. If there's something there that we can pick up and reuse, absolutely. So yeah, just get in touch, and I'm happily share that.
Thank you. So we have another question for both of us, which is how often can Flaminol be applied to moisture-associated skin damage? That's the beauty of Flaminol, isn't it? It can just be applied however many times needed. So I've alluded on my presentation. We usually say if it is related with incontinence, then every time that incontinence is addressed, so every time the patients are cleansed, um, because we'll be physically removing that barrier, then reapply it. There is no limitation to using Flaminol.
Yeah, no, I totally agree, and that's what we recommend in our pathway. We say a minimum of 3 times a day, just in case, obviously, there might be patients that aren't passing urine or feces up to 3 times a day, but majority of them do more. So we do the same principles of every time the patient's skin is cleansed, then you reapply, and it works really well. Couple of
Thank
questions for
you.
you then, Sol, that have come through for your
Yeah.
presentation. So the first one is, do you recommend using secondary dressings for management of IAD? And if so, what type?
So generally, no, we won't recommend the dressing. Number one, because if it is related with IED, usually that dressing will then trap that source of damage being urinary or fecal. And often because of the way moisture damage presents, because it's so diffused and irregular edged, you would struggle to fit a dressing into the area. So usually what we recommend is applying the Flaminol. Usually these patients might be wearing an incontinence pad, and that should be sufficient. But again, it's all about addressing the cause. So there's different devices that can be used. We don't have to necessarily go straight into a catheter if it's urinary source. Um, there are things like, so in UHL, we use something called a pure wick, which is an external device that is placed that basically sucks away the urine. And this prevents as well catheter associated UTIs. But so really the focus should be in addressing the cause. That's what's going to help the skin overall. It's not going to be about the dressings. It's how do we stop that source from causing further damage onto the skin. But generally, just to summarize, we wouldn't recommend the dressing. Thank
Fabulous. Yeah, and
you.
we wouldn't do that in neonates either, just
Yeah,
for exactly the same reason. So no, the product doesn't need a dressing, doesn't need secondary dressing at all.
yeah. So there's a question, Kelly, for you now. Are there any special considerations for premature babies when treating MASD?
No, so whether the baby's premature or full term, the same principles would apply in terms of how we would prevent it, treat it, diagnose it. Again, just making sure that we're aware that their skin is even more fragile than it would be if they were full term. And so it's around, we spend a lot of time with our neonatal nurses around to apply, obviously using techniques that are minimal contact as possible. So not only are we treating or preventing that MASD, we're not going to provide any shear or friction from his hands or our applicators in any way. So the only thing that we would do differently is when we're doing our education, talk about that minimal contact to the skin to prevent any skin stripping or anything additional that might occur with their skin being so thin and fragile. Is there anything different that you
Thank
would
you.
consider at all, Sol, in terms of the older population?
Um, Special considerations. No, I think we've touched upon everything on our presentations. Um, like I said, it's supporting the how we address the source of that damage. And then always bearing in mind that your care plans might take a little while to work, so don't feel disheartened. If you think it's not working just because you've applied it for 2 or 3 days, you haven't seen a difference straight away. Like I said, um, cells can take 14 to 20 days to reach from bottom of the epidermis layer to the top of the epidermis layer. And obviously, bearing in mind with an aging population, this will be even slower. So really take that key message away.
I think one of the other
Okay.
really important things to think about when we're talking about using Flaminol within MASD is that a lot of clinicians might see this as a debriding agent or might see it as an antimicrobial agent, and actually it's multimodal in terms of it does lots of different things. So, particularly around MASD, it is there for that antibiofilm, antifungal, but it's also there because it able to control that excess moisture. So because of the alginate that's within it, that's what is the kind of the party trick of this dressing when it comes to MASD. It is able to absorb that excess moisture and get that balance right on the wound bed. So it's looking at that wheel that I did in my presentation around the cleansing, the treatment, the antifungal, the moisture balance. This one product can do all of that. So it reduces that variation. It makes it more cost effective, as Sol was saying earlier, as well as being clinically effective. So it's just opening your mindset of what this product can do, and how it fits into your kind of pathway for MASD.
Yeah, thank you. We've had another question come through. As Flaminol is PO medication, I presume prescribable medication, can carers apply at each intervention, or does it have to be a nurse or nursing assistant? So certainly UHL, and because we really reiterate that apply it each time you are addressing that source of moisture. It can be applied by anyone. We will have registered nurses on our wards, so they will be supervising care, but certainly within our trust, it can be applied by anyone.
Yeah, and that's the same for us because we do get it from NHS supply chain and we don't need it in terms of an actual prescription. It's something that is regular stock on our ward areas and we can provide it on discharge as well. Is we do actually involve parents and carers, particularly with those neonates, to get involved and do that application. Then that's something that's easily transferable when they get home if that treatment needs to continue or even from a preventative point of view. So absolutely, it can be provided by a healthcare professional, but the application of it can be for anyone that you provided those instructions to.
Yes, thank you, Kelly. And there is a question for you. With newborn babies with healthy skin who don't have MASD, do you recommend a barrier cream or just water and cotton wool to cleanse at each nappy change?
Okay, so for our organisation in particular, we have had an increase of MASD in neonates prior to us putting our pathway in place. So we have taken the option that we are going to use barrier protection for all of our neonates, and particularly within our neonatal unit. So we will advise that a cleanse and spray as well as then a barrier ointment on that skin for prevention. And we're doing that so we can try and reduce those instances. And once we've kind of got to that point, we will relook at it and potentially look at how we can step back some of those approaches. But for now, as you'll see when we share the pathway, we do recommend to cleanse, spray, and protect. And that way that we can try and reduce the risk of it deteriorating further or even starting that MASD journey. Um, you don't always have to, but that's why I would say make sure you, as Sol said earlier, you need to look in your own organisation and kind of what products are available and what's being recommended. So that is something that's personalised to our organisation. So it might work for some of you, it might not work for others in terms of that early stage prevention.
Yeah, and certainly within my trust, I was mentioning earlier that we might recommend just the warm water with your emollient, but we also for healthy skin we do have something called Clinicep wipes. So you have your 8 ingredients in one wipe. So you have your barrier, your cleanser, etc. So we will also be looking at using a product that will have a barrier and that will act as a defense against MASD.
Fabulous. Well, I think we've answered all the questions, and I can't see any more that have come through. So, just like to take this opportunity again, just to thank you all for coming and spending your evening with myself and Sol. And again, just get in contact with eRivers if you want any further information. Thank you.
Thank you. Thank you, everyone.